Hello and welcome to the Clinical Care Options Infectious Disease podcast. I'm your host, Zachary Schwartz. During this episode, we're joined by Dr. Roger Bedimo from University of Texas UT Southwestern. He'll discuss strategies to overcome health disparities to improve HIV PrEP uptake. For more information about Dr. Bedimo, including the downloadable slides you can use to follow along with this podcast, please visit the links in the show notes. And to get access to all of our new podcasts, you can subscribe to the CCO Infectious Disease podcast on Apple Podcasts, Google Podcasts, or Spotify. Now let's get started and join Dr. Bedimo as he discusses PrEP.
PrEP guidance, and this is one I would like people to take home, which is that all sexually active adults and adolescents should be informed about PrEP for prevention of HIV acquisition. And anyone who ever asked for PrEP should be considered a candidate and offered PrEP. So that is very important. If somebody presented to your clinic and requested PrEP, there is no such thing as trying to find out if they actually are engaging in a behavior that places them at risk for HIV. That request alone to be an indication that PrEP may be a good option for that person. All roads lead to Rome, i.e. all roads lead to PrEP, either anal or vaginal sex in the past 6 months with someone with HIV, someone of unknown status, if one or more partners, or very important, if your patient had a bacterial ST in the past 6 months. This is a very important indicator for PrEP use. In fact, some healthcare systems that track the people who could be candidates for PrEP use this data. How many people have been seen with bacterial STI? And if you're not offering PrEP to these people, we're missing a significant opportunity. So, and that missed opportunity is the gap that we hope we'll all work together to close. That gap is the gap of people who are likely to benefit PrEP and those who actually offered and start PrEP. In 2022, with 1.2 million people likely to benefit from PrEP, PrEP use was limited at only 41% of men, 14.5% of women, and 23.5% of those aged 16 to 24. As you might know, age 16 to 24, this young age group is pretty much fueling the HIV epidemic currently. So significant inequities still exist in PrEP coverage. So when we see the PrEP coverage, PrEP is one of the 4 pillars of the Ending the HIV Epidemic initiative. And that pillar, the target by 2030, which is in the short 6 years, was 50% of PrEP coverage of those in need. And that is exceeded only by whites, 94%. And overall is still 36%. For Blacks, it's 12.8%, and for Hispanics, 24.4%. So we still have ways to go to get to where we need to be in terms of PrEP coverage. So the prevalence of HIV and PrEP use in transgender women in the United States. If you look at the US Preventive Service Task Force guidelines that came out last year, they highlighted transgender women because they are 34 times more likely to be living with HIV than the general population. And the prevalence of HIV in that group is estimated at 14% and is likely to be at underestimation. So 2019-2020 National HIV Behavioral Surveillance of 7 US cities showed high PrEP awareness, but low utilization. So think of it for a moment. There is high awareness of PrEP in this very vulnerable population, but low use. So I think the onus is on us to bridge that gap. More have heard from PrEP, but few are using it. What are the barriers? That's what we're going to soon look at. barriers. Barriers exist at the level of the patient, at the level of the providers, at the level of the system. And so all those barriers, we need to be aware of them and do our part to address them. So PrEP uptake and recommendations in people who inject drugs, 1 out of 10 HIV diagnoses in this group. And among people who inject drugs, PrEP awareness has increased slightly, but it's still really, really low. And PrEP use is abysmally low, 1.2%. So CDC guidelines recommend PrEP for people who inject drug or in combination with substance use disorder treatment, single syringe sharing program. So we need to always think about whatever intervention we are starting in people who inject drugs. We might want to think about combining those with PrEP provision. So actively countering these health disparities is important for us providers. And there are several, but we should not be discouraged by the magnitude and breadth of disparities. We should just be aware and be prepared to address them, intersecting racism, xenophobia, homophobia, HIV stigma. Racism affects clinical decision-making of healthcare providers. And a lot of this is implicit. So all of us should always be thinking, we might be prejudiced against somebody that is under our care. It's our responsibility to examine our own preconceived notions and possibly prejudices, and then address them. Anti-Black, anti-brown immigration policies, disassortive or assertive patterns of mixing. Assertive patterns of mixing is that people will only seek partners, friends, or whatever in their own group, community, while disassortive is people who go outside of that community. So some people are against this, and we need to be aware of that. Economic and legal hardships, others. So this addressing intersectionalities, I looked at here, we're presenting 5 different levels of issues that we may want to peel off one after another. So we have at the individual level, at the network level, at the community level, at the social and structural level, and at the epidemic level. But you can see things like mental health and poverty, unstable housing, substance use, criminal justice involvement as things that issues at the individual level that could not just get in the way of people taking care of themselves, preventing HIV, but actually also translate into those who unfortunately acquire HIV and live with HIV. Getting care is limited by these barriers. And then you have the network. HIV prevalence in your network depends. It's a high risk for you because people may engage in the same behavior and be a lot more likely to acquire HIV if in their network there is HIV circulation. That goes without saying. So whenever it prevents us from being judgmental, that if you see a high rate of HIV in the community, doesn't mean that everyone in that community is engaging in unhealthy behavior. It simply means that the network is quote unquote hot. So if you have only one sexual partner and you belong to that network, you may have a higher risk than others. And then at the community, structural and social levels, and so on and so forth. So let's just be aware of all this. And there is such a thing as PrEP continuum. And this is the Kaiser Permanente cohort, which looked at individuals who were linked to PrEP from 2012 to 2019, almost 14,000 of them, overwhelmingly male, in race and ethnicity, mostly white, and then Latina, Hispanic, Asian, and Black. And you can see that this is very different from the HIV prevalence, which is mostly in racial minorities. And discontinuation of PrEP is very common. More than half of the people discontinue PrEP at least once. So when you start PrEP, your job is not done. You need to see that PrEP persists over time. So again, PrEP disparities in this Kaiser Permanente cohort revealed a certain number of things. Of those aged 18 to 25, when they were compared to older people, they were less likely to be prescribed PrEP, less likely to initiate PrEP, but more likely to discontinue. I will repeat, These younger people, not only were they less likely to prescribe and to initiate PrEP, but when they started PrEP, they were even more likely to discontinue it. I would like to introduce now called PrEP to need ratio. This is the ratio of the number of people who use PrEP over the number of people who have a new HIV diagnosis in that group. So that means that they could have used PrEP. So that's that the need is high. The ratio is low if the number of people who use PrEP is much lower compared to the number of new HIV diagnoses. So this number allows us to look at racial distribution and geographic distributions of PrEP use. So race ethnicity data was available in this commercial pharmacy database and US Census data from 2012 to 2020. And there were 124,000, 35% of PrEP users in 2021. And when they looked at this PrEP to need ratio, and this is what they found. So the PrEP use, PrEP uptake is greater in the Northeast and much lower in the South. In all regions, the whites have an increasing PrEP use over time, while the uptick is much lower for Blacks and Hispanics. So expanding PrEP uptake, one of the tools is expanding the healthcare providers who prescribe PrEP. So to prescribe PrEP, you do not need to have HIV expertise. We're not treating HIV. We are giving medication to prevent HIV. And so it's important to expand the pool of people who feel comfortable and knowledgeable about using this modality to prevent HIV. So we should take lessons from contraception care in the United States. When contraception care moved outside of OBGYN, and that other healthcare providers, family medicine, internal medicine, pediatricians, APPs started prescribing contraception, the use of contraception increased significantly. And so it may be especially more important in rural areas because there's such a scarcity of specialists in those areas. So this is CDC PrEP prescribers in the United States. There is good news and bad news between 2014 and 2019. The good news is that there are increases in those who prescribe PrEP, significant increases, and all providers from 0.7% to 4.3%, ID providers from 14.2% to 34.2%. The number of PrEP providers increased from 9,600 to 65,800. So then the bad news is that in 2019, the South accounted for 52% of HIV infections, but the lowest number of providers who prescribe PrEP. So there is a significant gap, and that gap to be closed if you want to make progress in ending the HIV epidemic in that region specifically. So creating change, education of patients and healthcare providers, key to addressing inequities in PrEP uptake. So we have community-based education to raise awareness, combat implicit and unconscious bias, and instill trust in the healthcare system. There is an evidence that concordance in race and ethnicity between the patient and the provider might increase trust. So we need more minority healthcare providers, trusted community sources of knowledge, address unfounded beliefs about risk compensation that feed reluctance to receive PrEP. So some people said that you're using PrEP because you want to engage in wanton sexuality or something else. So positive messaging to patients with social networks and social media to improve the knowledge and support preventive messages and discuss all available options. Thankfully, since the introduction of PrEP in 2011-2012, options have expanded from oral to include injectable PrEP. So patients should be made aware of those options, and then one of them might appeal to them.
Thank you very much to Dr. Bedimo, and thank you to our listeners for joining in. As a reminder, to view the full program on contemporary HIV treatment and prevention 2024, click on the links in the show notes for this episode. And please be sure to check back for more episodes on important infectious disease topics. Thank you, and we'll see you on the next podcast soon.